Thanks for coming. I've been asked to talk about some things I've been doing in Houston for trying to make my cataract surgery a little bit more efficient. Always looking for ways to eliminate extra steps in my cataract surgery. And since I started using the nanoFLEX plate Collamer lens, I've come up with some, I don't know if they're completely new ideas, but at least things have been working out for me, and I'll show you a video. Of course, here's the plate lens. I've been using the Star plate lens for the last 10-12 years, but recently moved over to the Collamer lens in the last 2 years. So, what is a nanoFLEX? What is the advantage? I think one of the nice things is it's very easy to load for our technicians. I keep hearing that after a long time using the Alcon lens. The technicians really like how easy it is to load this lens. It's easy to inject. The injector is very small, and I use a 2.5, 2.7 incision with through clear cornea, and I'm able to insert the injector tip almost to the level of the anterior part of the bag, which is nice because I can, as I'll show you in the video, can inject the lens directly into the bag. nanoFLEX technology. Many patients would come back after surgery on post-op day 1. I would check their distance vision and their near vision, and I was amazed to see how many patients could see close to 20/20 in the distance, and then when I hand them something to read up close, they're able to read the J1, J2 line. That's not every patient, but it was something impressive that I wasn't seeing with other lenses I was using. This is an efficient, using this lens makes my cataract surgery more efficient. Like I said, it was a rapid insertion. The lens goes in fast, and I don't have to wait for the lens to open up. And it can open actually inside the bag, and when I show you the video, you'll know what I'm talking about. The main thing is what I changed in my cataract surgery is to be able to insert the lens without using viscoelastic. So after I remove the nucleus and the cortex, I can use a bimanual hand piece with my left hand through the paracentesis site, inflate the anterior chamber, insert the lens all in one step, and then the case is done. So I don't have to eliminate that extra step of going in with an INA handpiece, removing viscoelastic. This means I have less likely chance of having post-operative pressure spikes, and not to mention eliminates an extra step to the surgery, which I'm always looking for things to make the surgery more efficient. The blended vision is something I've been using a lot in monovision. The advantages of this lens is that it does create some types of accommodation, and it really delivers on the near vision. I said, like I mentioned before, many patients are close to 20/20 in the distance and have very good near vision. You get a really good wow effect with this particular lens. Financial advantage for the lens, I do, for blended vision and monovision, we do charge something for the refractive component, not for the lens itself, but to offer patients blended and monovision, we charge for the testing, testing to see if they would be a good candidate for monovision or blend vision. Here's a slide that basically shows you how we can set it up, how we sometimes set it up, and I usually find that with this lens we get about 1.5 diopters of accommodation. So Okay. You see in this video the cortex is removed, and I come in with an irrigating bimanual handpiece, and I'm injecting the lens directly into the bag. With one push, I can get the trailing part of the plate lens into the bag, and the case is over. So here's another an example of filling up the bag. The tip is so narrow, I'm able to get it in, and with one push, the case is over. So I basically do not have to go back in except for to hydrate the wound. And this is me hydrating the wound with BSS. I was using a little bit of viscoelastic inside the tip, and then I found I didn't even need that. So we just BSS inside the tip, and then inject the lens in without any problems. Here's a toric lens. I was trying the same thing. The toric lens is made out of silicone. It moves to insert the toric lens without using viscoelastic in the bag. Little trickier here. Sometimes the trailing part of the plate does not go into the bag, and using the irrigation handpiece, I'm able to push the plate in, and once I get it into position, I can bump it and tease it around until it's in position. Again, basically the same motion every time. Lens is in the bag. And sometimes I double check just to make sure that trailing haptic is actually in the bag. Smaller pupils is a little hard. So that is what I've been using the Collamer lens for, and it's really I've been getting really good results. The cataract surgeries, I believe, are getting more and more efficient. And is there any questions about what I've been doing? I think they want you to use this, Patrick. For the non-dominant eye target, I'm targeting for it depends on if the patient wants monovision or blend vision. Usually I'm targeting about -150, and that would give someone the intermediate area, and also we're able to see them get up here to about a -2. Any other questions?
Do you notice any difference in the corneas postoperatively with using just BSS to insert the lens versus using viscoelastic?
That's a great question. He was asking if I noticed any difference in the corneal clarity after post-op day one. Really, I'm using viscoelastic in the beginning of the case. So when the viscoelastic is there when I need it, when I'm breaking up the nucleus. But after that, I don't really need it. And take the cortex out. So the corneas look as good as they're going to look based on what I put in before. So if I have a really hard nucleus, then I'll use a thicker viscoelastic. But I got tired of using a thicker viscoelastic and then having to go in and get it out. And I was, getting all the viscoelastic out. Not only was it in the world of efficient cataract surgery is not that long, but getting it out was taking a while. And then I was having some pressure spikes. Probably 1 out of 7 or 8 patients would have a really high spike. This doesn't eliminate all pressure spikes, because I think there is some degree of trabeculitis that happens with some patients, and the pressure does go up. But the post-op pressure spikes have come down quite a bit.
What A constant do you prefer?
What A constant do I prefer? I think it's 118.4. 118. What is it? 118.6. Yeah. Any other questions? Not too technical? Okay. Thank you all very much for having me.